Is my screen, can everyone see my screen?
You want to switch the presentation.
Okay, sorry. See, it keeps sharing the same one.
That's good.
There we go. We can see it.
Oh, good. Okay, sorry. I was making sure it was the right one. Okay. Looks good now.
You're
good. Okay, good. Sorry about that. Alrighty, so for those who do not know me, my name is Danielle. I am one of the QA and trainers here at FireQuest. And so this training that we are going to discuss today is going to be on understanding trauma. So first, we like to start with our objectives of this training. So one is to become knowledgeable of the leading causes of PTSD, to better intervene with clients experiencing trauma, increase knowledge of how to screen for PTSD when working with clients and their families, understand screening for adverse childhood experiences and how they impact clients with other experiences, to become familiar with the 3 R's of trauma and how to successfully get to resolution or healing. So first we have a video here that I'm going to play, kind of explaining to us what trauma is. And so of course I knew it wouldn't have my play button here, so let me get the video up for us.
Danielle, we can't hear.
I think they just need to
do you
share
know that?
that.
So sorry. Let me get it.
The most important thing to know is that there's a difference between trauma and stress. As I like to say to people, life sucks a good amount of the time. We all have jobs and situations that are really unpleasant. But the moment that situation is over, it's over. The problem with trauma is that when it's over, your body continues to relive it. My name is Bessel van der Kolk. I'm a psychiatrist, neuroscientist, and author of the book, The Body Keeps the Score. I got interested in trauma on my first day working at the Veterans Administration. 1978 was the year, and the Vietnam War was over by about 6 or 7 years. The very first day that I met Vietnam veterans, I was just blown away. These were guys who were my age, who were clearly smart and competent and athletic, and they clearly were just a shadow of their former self. Their bodies were clearly affected by trauma, and they had a very hard time connecting with new people after the war. Around that time, a group of us started to define what trauma is, and in the definition of PTSD, we write, these people have been exposed to an extraordinary event that is outside of normal human experience. In retrospect, that shows us how ignorant and narrow-minded we were, because it turned out that this is not an unusual experience at all. People usually think about the military when they talk about trauma, but at least 1 out of 8 kids in America witness physical violence between their parents. A larger number of kids get beaten very hard by their own caregivers. A very large number of People in general, but women in particular, have sexual experiences that were clearly unwanted and that left them confused and enraged. So, unlike what we first thought, trauma is actually extremely common. There's a lot of debate of what a trauma is to this day. But basically, trauma is something that happens to you that makes you so upset that it overwhelms you. There is nothing you can do to stave off the inevitable. You basically collapse in a state of confusion, maybe rage, because you are unable to function in the face of this particular threat. But the trauma is not the event that happens. The trauma is how you respond to it. One of the largest mitigating factors against getting traumatized is who is there for you at that particular time. When, as a kid, you get bitten by a dog, it's really very scary and very nasty. But if your parents pick you up and say, "Oh, I see that you're really in bad shape, let me help you," that dog bite doesn't become a big issue because the foundation of your safety has not been destroyed. We are profoundly interdependent people, and as long as our relationships are intact, by and large, we're pretty good with trauma. It's a subjective experience, and what may be traumatic for you may not be traumatic for me, depending on our personality and our prior experiences. The problem with trauma is that it starts off with something that happens to us, but that's not where it stops, because it changes your brain. Much of the imprint of trauma is in that very primitive survival part of your brain that I like to call the cockroach brain. There's a part of you that just picks up what's dangerous and what's safe. And when you're traumatized, that little part of your brain, which is usually very quiet, continues to just send messages. I'm in danger. I'm not safe. That event itself is over, but you continue to react to things as if you're in danger. We're talking about survival. We're talking about staying alive. And so some people are into fight flight, or on a more primitive level, people's brain shuts down and they collapse. You have these automatic responses that are not a product of your cognitive assessment, they're a product of your animal brain trying to stay alive in the face of something that that part of your brain interprets as a life threat. And the problem then becomes that you are not able to engage or to learn or to see other people's point of view or to coordinate your feelings with your thinking. Traumatized people have a tremendous problem experiencing pleasure and joy. But the core issue is our hormones and our physiological impulses that have to do with survival. Your body keeps mobilizing itself to fight. You have all kinds of immunological abnormalities, endocrine abnormalities, and that really devastates your physical health also. Oftentimes the physical problems are longer lasting than the mental problems. And the other thing that is terribly important is the impact of poverty, or the impact of racism, or the impact of unemployment. There's other societies that are much more trauma savvy than we are, where there is not an enormous amount of income inequality. Healthcare is universal, childcare is universal. A culture like that really looks at what are the antecedents for certain forms of pathology. So the big issue is a political issue. How do we rearrange our society to really know about trauma so that people who grow up under extreme adverse conditions can become full-fledged members of society. The sense of community and people being there for each other is a critical part of surviving and thriving.
Get smarter fast.
Alrighty. So getting back to our PowerPoint here. Alrighty, so to kind of basically sum up that video there, what we kind of learned is that trauma is extremely common. But when your body continues to relive that stress for days, weeks, months, or maybe even years, that stress changes your brain, creating trauma inside of your mind, and then that trauma can eventually manifest into our physical body. So the problem with trauma is that it starts when something happens to us, but then it doesn't always stop there. So it changes our brain. So once your brain changes and you're in a constant flight mode, it can be hard to stay focused, feel joy, or experience pleasure until that trauma is healed. So it's kind of basically summing up that video there. Alrighty, so now we go into defining what trauma is. So we look at SAMHSA's definition, and if you're unsure what SAMHSA is, that is the Substance Abuse and Mental Health Service Administration. And so how they define trauma is individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. It is also events and circumstances may include the actual or extreme threat of physical or physiological harm, or the withholding of material or relational resources essential to healthy development. And these are events and circumstances that may occur as a single occurrence or repeatedly over time. So then we go into defining trauma according to the American Psychiatric Association. These features that distinguish a traumatic event, including the following. So sudden or unexpected events, the shocking nature of such events, death or threat to life or bodily integrity, and or the subjective feeling of intense terror, horror, or helplessness, a result of anything that disrupts one's sense of safety, and a normal response to an abnormal experiences or trauma disrupts the life path. So it's really basically to understand that trauma is relative. So trauma can manifest itself differently in different individuals, but the biggest thing there is making sure that your clients have a safe and comfortable place to work through that trauma is very extremely important. So giving them a very good space that they can actually be able to express or be comfortable with that trauma. So now we're going to go into types of trauma. So different types of trauma is physical abuse, sexual abuse, or emotional abuse, unstable or unsafe environments, separation from a parent, witnessing abuse or violence, neglect, serious illness, intrusive medical procedures, natural or human-made disasters, or severe motor vehicle activity or accidents. So within the last dedicated studies, this have shown that either witnessing abuse or violence can be just as traumatic as someone who experiencing that abuse or neglect, abuse or violence. Alrighty, so going into trauma is a subjective experience. So factors that may influence whether one experiences an event as traumatic. So these can look like developmental levels, they can inherit or learn resiliency, or external sources of support. So again, it's also to understand that trauma is relative to the individual. So just because you experience trauma from something does not mean that the next person will experience that trauma the same way that you have experienced that trauma or experience trauma at all. So for an example, two people can be in the same car accident. One person can walk away totally fine, sleep, and get right up the next day and do it all over. Whereas one person, it could take the other person a while to get back into a vehicle. They may not sleep well, and they may be reminded daily of that traumatic experience. So it's very important to understand that trauma is different for everybody, and it is relative to the individual. So now we go into some child development theories. And so we're going to focus on ages 0 to 2, and I'm going to kind of explain these different theories and their theories when it comes to child development. So child development theories focuses on explaining how children change and grow over the course of childhood. Now, these developmental theories center on various aspects of growth, including social, emotional, and cognitive development. So looking at the first theorist here, which is Jean Piaget. So he proposed an idea that children think differently than adults. Now, his theory provides a framework for understanding how children develop cognitive abilities. So when we look at no object permanence, that kind of means that a child in that stage can forget that items and objects or people still exist even if they are not present. Okay, so looking at Gordon Allport, he focuses on the different traits that make up personality. Although adult motives develop from infantile drives, they become independent on them. So his approach here favored emphasis on the problems of adult personality rather than those of infantile emotions and experiences. So for Gordon Allport at the ages from 0 to 2, he understands that childs can differentiate the difference between pain and pleasure and their physical self. Now, when we look at Kohlberg, his theory, he has a theory that focuses on how children develop mortality and moral reasoning. So the thinking process when a child or one decides whether a behavior is right or wrong, how one decides to respond to a moral dilemma, and not what one decides or what one actually does. So again, at that 0 to 2 age for Kohlberg, his theory is that these childs during this age like to avoid punishment, that they understand how to avoid punishment. Whereas we look at the last one, Erik Erikson, now he's a psychoanalytic theorist, and he focuses on the social interaction and conflicts that arise during different stages of development. So his theory suggests that encompassing the notion that we develop through an unfolding or of our personality in predetermined stages, so that our environment and surrounding culture influence how we process through these stages. So his initial stage is trust versus mistrust, which parallels that mental illness recovery stage, the acceptance of mental illness and trusting the idea of that recovery. Okay. So then we go into our self-awareness and individualization. So for normal development, they develop a growing sense of self-efficacy, develop knowledge that there are other significant people besides their parents, understand that certain needs cannot be met within family, and that certain events and experiences are not relevant to one's family. So in the end, the individual would experience autonomy, personal power, and independence, whereas certain development tasks may be missed or incomplete with abuse. So all energy and focus on the task of survival in a threatening environment. Just kind of discussing those differences there. So now we're going to go into the impacts of trauma. So there are 5 different impacts of trauma that we're going to get into today. So they are affective, cognitive, behavioral, physical, and psychobiological. So starting with the effective impact. So this, a person who has an effective impact to trauma has difficulty believing in what has happened, feeling detached or confused, maybe feeling numb or detached from that situation, or not wanting to connect with others, or becoming withdrawn from those around them. So this can look like having some fear and anxiety, depression, sadness and hopelessness, grief, anger and irritability, confusion, denial, disbelief or shock, guilty, shame or self-blame, like I mentioned, feeling disconnected or numb, and having that emotional or affective dysregulation. But when you look at the behavioral impact to trauma, now most responses to trauma are normal, are a normal attempt to cope, but some can be very risky. Now, traumatic stress reactions vary widely. So often people engage in behaviors to manage their after effects. So the intensity of emotions or the distressing aspects of that traumatic experience, some people may reduce tension or stress throughout avoidance, self-medicating like alcohol abuse, compulsive, this can look like overeating to some, impulsive or those high-risk behaviors, self-injurious behaviors, and then others may try to gain a control of their experiences by being aggressive or subconsciously reenacting aspects to trauma. So this can also look like difficulty concentrating or staying focused, having some sexualized behaviors, some self-injurious behaviors, lacking in age-appropriate peer interactions, or the oppositional, aggressive, or destructive behaviors. But like I mentioned, most responses to trauma are normal, but some can be very risky.
So Danielle, would this be for the behavioral? Would that be like how sex offenders? A lot of them were, were victimized when they were younger, and then they re-victimized.
It can be. Good. Alrighty. So now we go into the cognitive impact to trauma. So these are distortions can occur in thoughts about themselves, the perpetrator, other people, social connections in the world. So following a traumatic event, one would typically search for an explanation. So when there's no rational explanation to be found. Irrational beliefs, so the causes of the event may develop in order to gain a sense of control or predictability. So we're going to go into some examples of cognitive impact, but traumatic experiences can affect or alter cognitions. So from the outset, trauma challenges the just world or core life assumptions to help individuals navigate their daily life. So for example, it will be difficult to leave the house in the morning if you believe that the world was not safe, that all people are dangerous, and that life holds no promise. So the belief that one's efforts or intentions can protect one from bad things happening may make it less likely for an individual to perceive personal vulnerability. But however, a traumatic event, particularly if they are unexpected, can challenge those beliefs. So looking at some examples here of those cognitive impact. So self-blame. So this is either blaming self for the event itself or for not foreseeing or avoiding that event. May generalize experience of betrayal by one person to mean that no one is trustworthy. May see self as bad or lacking in some way that justifies bad things happening to them, or may contribute to the loss of faith in justice, God, or anything in the future. All right, so going into the physical impacts of trauma. Now, some people who have experienced traumatic stress may present initially with physical symptoms. Now, there's a significant connection between trauma, including adverse childhood experiences, which we'll kind of cover a little bit later in training. So these can look like health problems, sleep problems, eating problems, an exaggerated startle response, muscle tension, fatigue, or problems regulating body pain. So when we talk about the exaggerated startle response, what we mean now, these are core clinical features of hyperplexia. They are an startle response to an unexpected stimulus or stiffness. Now, the abnormal startle response is generally present from birth, or it can be inherited in cases and may be even noted in utero. Now, what do I mean by hyperplexia, or what does hyperplexia mean? It is a rare hereditary neurological disorder that may affect infants as newborns or prior birth. Now, individuals with this disorder have an excessive startle response. This can look like eye blinking or different body spasms to that sudden, to any unexpected noise, movement, or touch. So kind of explaining that there. And so then we go into the psychobiological impact of trauma. Now, structure of the brain is dynamic, so meaning that the brain structure is interactive with brain functioning. The number of receptors in the brain for different receptors can be increased or decreased in a response to many factors, including stress. Stress changes neurotransmitters and hormonal activity, both in the brain and in other parts of the body, which then produces physiological responses such as increased heart rate, respirations, blood pressure, diversion of blood flow into skeletal muscles, and increased alertness. Now, childhood trauma and PTSD are associated with chronic changes in these areas of physiology. Traumatized children may have higher resting pulse rates and blood pressure, greater physical tension, and hypervigilance. So to continue on with psychobiological impact, it is important to note that everything a person does, thinks, and feels is associated with brain activity. So traumatic events have the potential to change or alter the brain's functioning. So when changes occur over a long period of time, it may contribute to maintenance of trauma symptoms and may also contribute to structural changes in the brain. So in one study, children who have experienced interpersonal trauma, such as abuse or exposure to domestic violence, were found to have smaller intracranial volume, which is their brain size, lower IQs, poorer grades, smaller corpus callosum, which is the part of the brain that connects the right and left hemisphere, and higher dissociation scores than children who had no trauma history. Okay. So now we're going to watch a video by Miss Mary Vaccaro where she explains Dan Siegel's hindbrain. So let me get that pulled up for us really quick.
Hi, I'm Mary Vicario, and it's been my joy to be a part of the Resilience Project for the last 5 years. Today, I get to talk to you about the handbrain, and I love it so much because it allows me to bring a model of the brain with me wherever I go, and I'm Italian, so I talk with my hands, so it's just a win-win all around for me. Feel free to do this with me. Between your wrist and your elbow is your spinal column and something really important called the vagus nerve. So the vagus nerve actually releases all of our feelings into every organ of our body. So literally, we feel our feelings in every organ of our body, and we don't get to decide when that happens. It just does it. So in fact, those feelings are the feelings that frequently drive our behavior, especially if it's something we do very quickly, or if it's something that gets us in trouble, or the things that bring the people we serve to us for help often come from those feelings they get in their body, not in those thoughts that we're so proud of, but in these feelings. The next part of our brain is the brain stem. It's the palm of our hand, and it's in charge of all the things we don't think about, all the things that keep our body going that we don't think about. For example, breathing, digestion, bladder and bowel control, which means that's not under your conscious control sometimes. Arousal, the type of arousal that hopefully has you awake right now while you're watching this video, and the type of arousal that makes you want to do things far more interesting than watch this video. It's also in charge of how much information enters your brain. And if you're on the autistic spectrum or you have trauma, it actually lets in extra information because it doesn't know what you're going to need to be safe. And that extra information can become very overwhelming very quickly. In fact, it makes all your senses stronger, so things are brighter and louder and they feel weird in your mouth and your clothes feel weird and get very stressful. And the other reason it can get very stressful is that all the information that enters our brain goes immediately to our fear center, which is the next part of our handbrain, which is our thumb. The fear center, also known as the limbic system, is in charge of 3 very important things that I like to remember through the word FAR. It's in charge of felt safety, attachment, and regulation. And it likes things to happen in that order, in fact. So when the information comes into the brain, it immediately goes to the fear center and decides safe or not safe. And if it's not safe, it keeps our thinking brain offline. But if it is safe, it lets the next part of our brain, our cortexes, our thinking brain, come online and give it a hug. But when it's not safe, throws it offline. So when you're not feeling safe, it doesn't allow you to attach and work cooperatively with others. And when you can't attach and work cooperatively with others, it also doesn't allow you to regulate. And you can look like you're out of control. And it might look like a choice, but when your fear center's in charge, it's not a choice, because what it is thrown offline is your thinking brain, which wraps around the fear center and has all those wonderful thoughts and all those wonderful things we've practiced doing housed in it. But when the fear center gets afraid, throws it right offline. And the only part of our brain we have conscious control over is our thinking brain. So when our fear center throws it offline, all of those thoughts we're so proud of and that we've worked so hard on to help us control our behavior, they are out of our reach. And if the fear center can't tell, should I be afraid or not afraid, it always errs on the side of fear to keep you alive. So we want to find a way to get a message from the thinking brain to the fear center so they can work together when we're afraid. And we're going to look at how to do that. So our vagus nerve and our brainstem think in sensations and feelings. Our fear center, our limbic system, thinks in feelings and pictures. And our thinking brain thinks in pictures and words. So you may have guessed it, the passport from the fear center to the thinking brain are the pictures. When we can create a picture for what we want, we have a better chance of getting a message to that thinking brain, bringing it back online so it can hug our fear center and help us feel safe again.
Alrighty. So then we're going to kind of touch on some different brains here. Oh, sorry. So the first one here is a healthy brain. It is an image of a healthy brain. This is the instinctive part of the brain known as the primitive. It contains the brainstem, the limbic region, and the amygdala. So this is the part of the brain that is responsible for basic functioning. So like breathing, blinking, heart beating, flinching, and digestion, and etc. So what's one thing we want to kind of focus in is you look at the temporal lobes, you'll see here that they're very connected, focusing on how connected they are. Whereas when we go to an abused brain, now this is an image of an abused brain. So this PET scan is from an orphan who was institutionalized since birth. It shows the effects of extreme deprivation in infancy. So as you can see here in this image, you'll see the temporal lobes, they are not really connected here, which they regulate emotions and receive input from senses, and they are nearly gone here. So looking at the first one image here, you'll see how they're very connected. And when you look here, you'll see again how those temporal lobes are pretty much non-existent there. Now, when we look at this image here, this is an image of a 3-year-old child. If you look there, it's either to your left or right. You look at that normal brain, you'll see how enlarged that image is, whereas you'll look into the other image there of the same 3-year-old from extreme neglect, and you'll see how small their brain is. So again, trauma can affect not only our physical self, it can also affect our brain and changes in our brains. So now we talk about the end results of trauma. Now clients with trauma histories will respond to their trauma history in the present, so they can discern that the contexts have changed. Clients with multiple traumas may blend those experiences together. Responses may seem extreme, so they may get very defensive and self-protective, which is considered their coping mechanism. Maladaptive behavior is the attempt to master a difficult environment. So looking at some end results of trauma, this can look like unstable relationships, lack of trust in others, difficulty concentrating, the lack of self-control, educational delays, lack in confidence in self, opposition to rules and directions, poor peer relationships, depression or mood swings, motivated by immediate awards, or the lack of or unrealistic long-term goals there. Alrighty, so now we go into discussing Maslow's hierarchy of needs. Now, Maslow's hierarchy of needs is a theory of motivation which states that 5 categories of human needs dictate an individual's behavior. So when we experience trauma, which most of us have on some level right now, we sink lower on the pyramid. We may even sink to the bottom. Like when we were little, our focuses narrows as basic needs become more tangible and more important. So looking at Maslow's hierarchy of needs, starting at the bottom is those physiological needs. So things like air, food, water, shelter, sleep, clothing, and reproduction. So those are those basic needs. Then you go into those safety needs, which are personal security, employment, having a job, having different resources, making sure our health is in order, and then property. Then you go into love and belonging. So looking at those relationships, so friendships, intimacy, family, and just having that sense of connection. The next step on the pyramid is that self-esteem. So having the respect, the self-esteem, your status, different recognitions, strength and freedom. And then the last on that pyramid is self-actualization. So the desire to become the most that one can be. So our last, this may be the last or second to last video where Miss Mary again is going to discuss successful trauma resolution. So again, let me stop sharing my screen so I can get that pulled up for you. And there we go.
So now I get to talk with you about the 3 R's of successful trauma resolution. The first R is re-experiencing. The second R is releasing. And the third R is reorganizing. But before we get onto the path of the 3 R's of successful trauma resolution, we have to look at where we meet the people we serve, because they're not on the path yet. They're still caught in yet another R called reenactment. And the important part of that word is the act. It is the reenactment that causes the acting out behaviors, as they're often labeled, that bring people to our door. And what their brain literally is doing is reliving the trauma in the present moment without their thinking brain knowing it. And this reenactment is not a choice. It comes from the part of the brain we don't have conscious control over. And it feels like the trauma is happening all over again. It's a very lonely, frightening place to be. And when they're done, it may look like they have gotten some relief, but they have not. That person is caught in the trauma of the past and reliving it in the present moment. They don't feel safe. They are just as frightened now as they were when the trauma happened. And it's not a choice. It's not a relief. And it's something we actually can help them move beyond. Where the 3 R's of trauma resolution comes in is that the first one, re-experiencing, can happen depending on how we react to someone's reenactment. If we reflect the fear that we see and we honor that they had the courage to show us that fear, and we connect them with the fact that they're safe and in the here and now right now, we literally allow that person to re-experience that trauma, not from a place of being alone, but from a place of connection. So when you get to re-experience that trauma with a safe other, whether it's through drawing or writing, the person no longer feels alone in that moment. And it literally takes them off their hamster wheel of reenactment. You have helped heal their brain. So the second R is when we honor what they've done to survive, and that allows their brain to release their trauma from the central nervous system and put it in the memory center of the brain where it belongs. We are helping their brain release their trauma, and we're also giving them dignity for the survival they have already done that has gone unrecognized. And then the third R is my favorite, because once you've released it, you are aware that the trauma has happened, but it is no longer the central organizing feature of your life. Then all the energy your brain was taking up, keeping you in the past and looking out for the future and not allowing you to live in your present moment, is freed up for you to decide what you want for your present and your future. You literally now can connect with people, feel safe enough to reorganize your life around what you want your life to be.
Alrighty, so just kind of sum up that video there. She discussed those three successful trauma resolution. So just starting with reenacting. So reenacting means that the person is reliving the trauma in the present moment. So depending on how we respond to someone's reenactment, a person can re-experience or process their trauma in a more realistic way. So giving someone the space without judgment to feel that pain, loss, or any emotion that connects to that detailed memory of that event. So when we honor what a person has done to survive, we allow their brain to release that trauma from the central nervous system and put it in the memory center of the brain where it belongs. So a person can live without feeling compelled to relive or repeat that traumatic event, either consciously or unconsciously. So once trauma is released, again, they are aware that the trauma happened in the past, but they're no longer going to experience or see it as clear as a recurring danger in the present here. So now we go into keys to providing trauma-informed care. So you need to presume that our clients have experienced trauma. So instead of what is wrong with you, maybe asking what has happened to you. Need for an understanding of the vulnerabilities or triggers of survivors to provide supportive care and avoid re-traumatization. So survivors need to be respected, informed, connected, and hopeful regarding their own recovery. Also need to understand that there is a correlation between trauma and symptoms of trauma. So like substance abuse, eating disorders, depression or anxiety. To continue on, you want to set up a calm and nurturing environment. So be conscious of a person's demeanor. So if someone is beginning to move from a calm, continuous state to a state of emergency, if so, model caring and compassion and adjust the environment if possible. Be aware of language being used, so using a diagnosis when referring to an individual. So when a clinician is caring for a patient with any of these conditions, they may want to use a trauma lens or assume that a history of trauma may have contributed to these conditions. So using a trauma-informed approach and offering serves to heal from past trauma, along with traditional medical therapies. These may also lead to better outcomes and experiences of care. So now we're going to go into adverse childhood experiences, which is ACE. So ACEs are potentially traumatic events that occur in childhood. ACEs can include violence, abuse, and growing up in a family with mental health or substance use problems. Toxic stress from ACEs can change brain development and affect how the body responds to stress. So is going to be our last video here. This video just going to explain what ACEs are for us.
A child's experiences early in life are important building blocks for the developing brain. Genes, nature, are like the blueprint. They provide the basic framework for brain development. However, genes do not design the brain completely. Environmental influences, nurture, fine-tune how the brain works by shaping which brain connections get used. Connections that are used more grow stronger and more permanent, whereas ones that do not get much use fade away. Together, genes and the environment build the foundation for all future development. Safe, stable, and nurturing relationships early in life lead to healthy development. But children's brains capture other experiences as well. Stressful events. However, not all stress is bad. Positive stress involves normal childhood experiences, like starting daycare or meeting a new person for the first time. This stress is essential for healthy development because it helps children develop coping skills and confidence. But when stress is frequent, chronic, and uncontrolled, it is toxic to children, especially when they do not have a caregiver to provide support or buffer the stress. Adverse childhood experiences, ACEs, such as abuse, neglect, exposure to intimate partner violence, parental depression or addiction, and poverty, are toxic stressors which could lead to lifelong changes in learning and behavior. ACEs early in development can impact social, emotional, and cognitive functioning, increased risk-taking behavior such as drinking and substance use, and increased risk of disease, disability, and social problems later in life. The question is, how do adverse childhood experiences impact a lifelong development? One of the most important systems in our body is our stress system. It's activated when we experience stress. We become alert, our heart rate increases, and so do our stress hormone levels, cortisol and adrenaline. Our body is ready to react, what is known as fight or flight. A short period of time after the stress is over, or if a child receives support from a caregiver, the stress response turns off and the body returns to a normal state. Adverse childhood experiences create stress responses that stay active, and without the support of a caregiver, the system has difficulty shutting off completely. This constant and prolonged activation can affect immune system functioning and increase the chances of sickness, infection, and disease. Prolonged activation of stress hormones is also toxic to the brain. Certain areas of the brain are more vulnerable to toxic stress, including the executive center or the brain's control center, an area important for solving complex problems, attention, reasoning, impulsivity, inhibition, and learning. A second area is the emotional center, the brain's alarm system, which is involved in processing and interpreting emotions and the ability to control impulses. The third area is the memory and learning center, the brain's filing cabinet, which plays a major role in learning and the formation and retrieval of memories. Science shows that adverse childhood experiences impact all of these brain centers. Behaviorally, what we begin to see is emotional distress, poor emotion regulation, greater impulsivity, learning difficulties, and physical and mental health problems. More recently, science has begun to look at how ACEs cause changes in gene expression through a process called epigenetics, which helps us understand how nature and nurture interact. Epigenetics causes changes in the way genes work without changing the DNA code itself. This occurs through chemical changes influencing how the code is used. In other words, genes are like the hardware in a computer. They determine the boundaries of what is possible. However, we need an operating system to tell the hardware what to do. Epigenetics is like the operating system directing the function of a gene's DNA hardware. The genes we are born with are the genes that we have for life, but experiences like nutrition, exercise, smoking, stressors, and relationships all affect our biology. Adverse childhood experiences are associated with epigenetic changes related to stress, brain development, cognition, and systems associated with mental and physical health. Changes that happen early in brain development are more likely to be enduring and are possibly passed on to future generations as well. The good news is that positive, supportive relationships at any stage in life can make a difference. However, supporting families and children early on will help prevent many of these negative outcomes. One of the key ingredients for healthy development is having warm, loving, and actively engaged caregivers. This involves promoting serve and return interactions, where caregivers actively and warmly engage with the child, making eye contact, responding to sounds, words, gestures, emotional needs, and sharing experiences like reading and play. Providing programs that support caregivers to strengthen these abilities are the blocks that build healthy foundations for life.
Alrighty. Alrighty, so this is a adverse childhood experience and ACE questionnaire that can be done with clients. So if the ACE score is between 1 to 3 without ACE associated health conditions, then the client may be at immediate risk for toxic stress. If the ACE score is 1 to 3 and the client has at least one ACE associated condition, or if the ACE score is 4 or higher, then the client will be at high risk for toxic stress. And this is, if you would like this questionnaire, I can send it to you, Ms. Anessa, after training. So looking into adverse childhood experiences, so data shows that there is a striking association between trauma and illness. So the Seminole ACE study provides estimates of odd ratios for having conditions in adulthood if the person has experienced ACEs in childhood. Now, ACEs in childhood are strongly correlated with adult disease. So people who have experienced 4 or more category of ACEs have 2 times the rate of lung and liver disease, 3 times the rate of depression, approximately 3 times the rate of alcoholism, 11 times the rate of intravenous drug use, and 14 times the rate of attempted suicide. So looking at the 3 types of ACEs, they include abuse, neglect, and household dysfunction. So looking at abuse, this can be physical abuse, emotional abuse, or sexual abuse. This can be physical neglect or emotional neglect. And as far as household dysfunction, this can look like mental illness, having an incarcerated relative, seeing their mother treated violently, substance abuse, or divorce. Now, developmental trauma, which is also called ACEs, these are chronic family traumas, such as having a parent with mental illness or substance abuse, like I mentioned, losing a parent. So these are all those 3 types of ACEs. So collecting trauma history. So it is not necessary to take a detailed past trauma history to create an environment that is receptive and responsive to their trauma. It can be overwhelming for those who do not have healthy coping mechanisms developed or they are in active substance abuse. So instead, look for markers of trauma to help guide treatment offered. So when we look into those trauma markers, these are health conditions that are highly correlated with recent and past trauma. So these include heart, lung, or liver disease, obesity and diabetes, substance abuse or overdose, or mental health, things like depression, PTSD, and anxiety. So here's just an image of some possible risk outcomes. So the possibly behavior risk outcomes can look like lack of physical activity, smoking, alcoholism, drug use, or missed work. And then the physical and mental health risk outcome can be severe obesity, diabetes, depression, suicide attempts, STDs, heart disease, cancer, stroke, COPD, or broken bones. So some approaches here. You want to use a trauma lens. So again, assuming that a client's trauma may have contributed to current medical conditions. Using a trauma-informed approach and offering serves to heal from past trauma, along with traditional medical therapies, may lead to better outcomes and experiences of care. Numerous behaviors correlated with having experienced trauma or having PTSD that are often attributed to personality disorders. And these too can be markers and include being reactive, easily triggered, easily offended or anger, withdrawn, or disassociated. So other things to consider, that it is important to acknowledge that many providers and staff themselves have history of trauma. So working with patients with severe illness and such significant histories of trauma can be vicarious. Consciousness, awareness of our own traumas help us maintain a professional and therapeutic stance towards our patients with trauma. We can use guidelines for inquiring about trauma and past trauma, which are known to be less triggering or dangerous for our patients and less overwhelming for providers. Here, guidelines for inquiring about trauma is to 1, assume history of trauma without asking, screen for impacts of past trauma instead of the trauma itself, inquire about trauma using open-ended questions, and then use a structural tool to explore past trauma experiences. So we have some links here to some of the videos and things that we introduced in this training here. And then we do have, it is 4 o'clock, but we do have some QA and discussion if you have it. And then if not, here is a QR code for you to complete a survey on this training. You can either take a photo of the link or you can take a photo of the QR code and that survey should pop up for you. You can go ahead and give us some feedback of how you felt about this training. That is going to conclude this training today. So if you don't have any questions, we can go ahead and end. Thank you all for hopping on this training, and have a good the rest of your day.
Thank you, Danielle.
Thank you. Thank
Bye.
you. Have a good one.